Good morning, everybody. All right, we're going to get started in just a second. Give people a few minutes just to kind of tune in because sometimes this is a little delayed. We'll see how it goes, okay? If you can hear me, just tell me, give me a thumbs up or tell me that you can hear me, Doc. I can hear you. All righty. Everybody's saying good morning. Good. I got a thumbs up. That means that you can hear me. All right. I just hate talking to myself, and sometimes I do that on these devices. Okay. Let's see how many people will show up in the next 10 seconds, and then we'll go ahead and get started, okay? I have my Unicity Unimate drink here. Hopefully you do. You don't have to have that, but you need to have either this for your fiber. I bought this for old time's sake, but if this is what you like too for your fiber just before you take your meals, then this is cool too. All right. But I hadn't been able to stomach in this while. That's why the bag is still half full, even though I hadn't been able to stomach. This is it has several different types of soluble fiber. So that's what one of the things we're going to be touching on just briefly because we've gone over it so many times before. So today's agenda is basically just kind of go through the slideshow as we usually do, just to kind of give you some of the science. And then I'm going to show a couple of videos. One is an explainer video and one is kind of a cinematic video. And you're going to tell me which one you like the best so I can decide which one are we presenting the next time around. But today's topic is going to be a little different, primarily because we're going to be discussing the GLP-1 drugs versus surgery. And I'm going to show you my take as I agree with the recent literature that's beginning to come out about that. They're not that competitive anyway. But I'll show you some of the pros of the GLP-1s, the cons of the GLP-1s only. Show you some of the pros and the cons of the surgery only. Then we're going to mesh them together and see what we get out, see what the new studies are actually showing out there in the video. In that slideshow part, I am going to also give you a couple of situations, a couple of live cases. I showed last week a couple of them. I'm going to show this week the same kind of a thing. But just to kind of give you an idea, why I don't think that treating obesity or treating health is one tool. I just don't. Why I think that also that what I'm going to be finalized in saying is that you have to have guidance. You hadn't. Some of you are going to medical school. Some of you going to dietitian school. Some of you have done a lot of research on YouTube, and you get a lot of different answers. But what I want to do is to pull whatever we're going to do with some sort of teaching, with some sort of knowledge, and then taking that knowledge, optimizing it, and putting it into action. That's extremely important because I see so much, and I see too much of where you can get GLP-1 drugs. You can get them at Costco. What kind of instructions do you get at Costco? What kind of instructions does the doctor give you? I want to know. I'm not going to be too critical because I want you to get healthy. What I want to show you is a patient going awry because they didn't get any instructions. They didn't get any measurements as to where they were going. You know what the single measurement they got, which in their mind meant they were successful? You all know the answer to that, right? The bathroom scale. They lost weight, lost 90 something pounds on GLP-1s alone. Came to me a while back and said, Doc, I don't need to have surgery. I'm losing weight on my own. And then try the GLP-1s and said, see, I told you I lost weight on my own. See me now? So anyway, we're going to discuss that. All right. I think I got enough people to go ahead and get started. So I'm going to be putting my glasses on so I can see what I'm doing. Sharing my slide presentation. I'll share the whole screen. If you think I'm talking to myself, I am, because I need to figure out what I'm doing. All right, I think this is the one. This is not the one. All right, this presentation, we're trying to, as I told you before, we're trying to upgrade our presentations. Just open the recent one. This is the one that I want. I don't know why it disappears. But let's get started, and people will come in, and as they come in, I'll let them in. But what I like about this slide is this part right here. Life's not just about living longer; it's about living healthier longer, and that's obviously becoming more important to me because I'm living longer, and I want to stay healthier longer. Primarily because if I get to the point that I'm bedridden or I have to use a walker or things of that nature, then my quality of life suffers. And then I know too many people who wonder, is life worth living at that particular point in time when your quality of life is gone? And unfortunately, I have some of my old mentors that lived quite a long time and still had that brain capacity and still, but they were just not able to get around and do very much. And as you watch that, and I'm not telling you guys anything new. You all have seen it in your elder people that you knew or know. And every week I get bad news every week about somebody that was a physician or somebody that just passed away. Too soon. Too soon. And one of the things that I ask people sometimes is basically when we quote the age of yep, at the age of 75 that person passed away and they led a good life, or that person was 85, yeah, they led a good life, and that the person gets to be 95, yeah, they had a good life. That's what we're saying about them. But you ask them because I have. If you had the opportunity to do it all over again and you could live the length of life you're living now, but get around and do more, would you want to live that long? And the answers are always a resounding, yeah, I want to live. I want to live now. I'm 90 years old. I want to live now. That's what they tell me. So we're making judgments on them, and because I hear it all the time. Yeah, that person passed away. Well, they led a good life. They were 85. They led a good life. They weren't finished with their good life. It just so happened that they just, along the way, made poor choices. And that's what this channel is all about. This is what I'm trying to do, is that before it gets to that particular point in time, we're making poor choices right now. And the reason I tell you all these stories, sometimes very dismal stories, and I get it, but I'm a physician. I'm not supposed to be one of the YouTube influencers that only give you happy stories. I'm not. But the reason I tell you these things is because there is a miracle that can happen, and it's called change. And if you're in your 50s, 40s, 30s, you have the greatest opportunity to get to that age of 90 and want to live longer and are healthy and moving around and say, this life is great. You've got that opportunity. I've got that opportunity. And I'm significantly older than most people on this program. Maybe except for Patty. I'm just kidding, Patty. Anyway, that slide. All right. So that slide says engineering our metabolism. All I want you to remember these four things. If we're able to change to live longer, we've got to change these four things. We've got to do some sort of fasting. We've got to exercise, and not just walking. We've got to do resistance training. So today, I'm going to show you how to exercise with the bands. All right. I keep telling you I was going to bring these things, so I finally got them out the closet because I use mostly free weights. But I'm going to show you how these things, and they have the little weight on here. You can get these from eBay. You can get these from Costco. You can get these from any place. And they're not that expensive. So even when you want to travel, most of the places I travel, they have gyms. But if I go to a place like an Airbnb where I know they don't have a gym, I'll take this with me. This is 5 pounds. I think the green here is 7 pounds. But I'm going to show you how powerful this little 5 pound thing can be. Because we talk about progressive resistance training. I'm getting that away from, we're not getting away from the walking. The daily walking is important. At the zone 2 is important, like we talked about. So don't get me wrong. I'm not saying stop walking and do this. I'm saying do this in addition to. And so I'm just saying that it's a little easier than people make it out to be. You could be in this chair. I can do this chair and put this thing around this chair and do my shoulders. I'm going to show you that. And with just 5 pounds, I'm going to show you what progressive resistance training is. With just 5 pounds, stretch with just the 5 pound bands. The 5 pound bands, you can put your legs further apart, put them further apart, and they become all of a sudden 7.5 pounds or 8 pounds or 9 pounds, just by how you position yourselves. And then progression means progressively increasing the what do you call it? Not necessarily increasing the weight. That's what I'm going to show you. I'm going to use one 5 pound band, and I'm going to show you how to do progressive resistance training by just doing a fuller range of motion, by doing slower exercise. You're going to stimulate that muscle in a different way with just the 5 pounds. So fitness, fiber, like I told you before, here, the balance are either here, the psyllium husk. Psyllium husk is great, all right? But they both cost about the same amount when you buy them in packages, but this one I can stomach. And then protein. I can't overemphasize that. You know that. And I'm going to show you a result of one of the slides that I'm going to show you is going to be just that, where a person lost their weight, didn't pay attention to protein, didn't pay attention to resistance training, but paid attention to that number on the scale and got sick. But they didn't feel it yet. But she significantly reduced her lifestyle. Because I put her on the machine, the VO2 max machine, which is the #1 telltale sign, better than blood pressure, better than blood sugar, and all that. That's what your longevity is going to be. So even at her young age, her VO2 max came back abysmal. Abysmal. A VO2 max is the amount of oxygen you're delivering to your body that your cells can use. So it kind of measures how your heart and your lungs are working together. And there have been studies over the past many decades that have shown your VO2 max correlates with your longevity. Okay? All right. Insulin resistance is where we're basing most of our diseases. 80% of all disease processes come from insulin resistance, even some cancers. Okay? So I don't want to go into the vivid details of insulin resistance, but you guys have heard this before. You can Google it, you can WhatsApp it, you can look up on YouTube videos and say, what is insulin resistance? Everybody on there will tell you the same thing. Most of our chronic diseases, diabetes, dementia, Alzheimer's disease, high blood pressure, type 2 diabetes, pre-diabetes, and obesity originate with insulin resistance, meaning that your insulin is too high and has been too high for too long. At a stretch, daily, it's too high and it stays high. We want to give that insulin chance to come down. We want to give it a chance to come down and stay down for a while. And we could do that by eating the right foods and taking a break from eating. That taking a break from eating is called fasting. Okay? It all blends in here. Those 4 pillars that I talked to you about, those 4 pillars we concentrate on will decrease insulin resistance, will decrease your high blood pressure. I'm going to show you what my blood pressure was this morning without drugs, as opposed to what it was when I'm going to show you some of the pictures on the video here. I don't know if I can show. I have it on my eye health. I have this little thing here. It's called, it takes my blood pressure. So I took it thinking that I could save the picture and show it to you, but when I tried to swipe it and save it as a photo, it wouldn't allow me to. Let me see if I can take it on my phone here and turn it around. This is my blood pressure numbers for the day. I don't know if you can see them or not. But anyway, so I'll just tell you what it is. At the August 1st, 2026, I did it 5 minutes thinking that I could get it on this slide, but I couldn't. I'm not smart enough yet. But it measures it 3 times just to get a good range of motion. So my first blood pressure was 116/72. Second one was 94/61. Last one was 89/63. We used to think that 120/80 was a good blood pressure. We now know that that's not. We want it down lower. We definitely want that lower, that diastolic number down lower. Some of you didn't even know that. Some of you probably don't think that 120/80 is good. It used to be. We used to think that it was good, but now we know that it's still associated with elevated CRP and things of that nature. So the American Heart Association adjusted the numbers down. More importantly, that lower number. So the lower that number can get, below 80, is a good thing. So my low number, first one was 72, next one was 61 and 63. Okay. Anyway, insulin resistance is what I am defeating. I hadn't defeated it yet, but I'm getting there. So I want you to get there with me. Okay. All right. Knowledge is power. Why am I giving you these lectures, these long, boring lectures over an hour and a half on a Saturday morning when you could be out doing something different, shopping? Knowledge is power. Knowledge is power, and it gives you potential. Okay? Because when you take this knowledge in, you got potential. You say, and that's what I'm going to ask you at the end of this video, as I always do at the end of this session, as I always do. What did you learn new today? Because I guarantee you're going to learn something new today. It gives you potential. All right? What do? That potential gives you an opportunity. Beginning to make sense? What does opportunity have to do with anything? The opportunity gives you the power to take action. Because without that action, you don't have anything. If I just give you the knowledge of how to do these resistance bands, and you don't go out to Costco and buy you some resistance bands to take along in your suitcase when you're traveling, then you're not making a change. You're not taking advantage of that potential, that opportunity. So take advantage of it, because consistent action is how we're going to transgress through this rest of this life. I watched it on a YouTube channel the other day. What's the name? Shepherd. She's a 90-year-old bodybuilder. Y'all seen her before, right? Looks like she's like 50. She's 90 years old. It's an inspiration to me. All right. All right. So let's keep going. This is an inspiration. This young lady is an inspiration to me, a physician. And she's they take a like a little family picture, and you can see they have that nice little dresses on. But here she's the one that wanted to change her lifestyle, because she wanted to be around to go to their whatever their futures. She wanted to be around for their futures. All right. This is her looking here. She's beautiful. Always has been beautiful, but she had issues. She had issues with insulin resistance and the problems that insulin resistance creates. Diabetes, hypertension, all that kind of stuff. Same thing that I had. Okay. She sent me this thing. Sent me a picture of this metal. Oh, what is that? Titan Z? That's not how you spell my name. Titan. My name is Titus. She said, well, that ain't about you, Doc. Everything ain't about you, Doc. Okay, what is it? She said, well, I wore it while I was winning this this contest. I wore it when I was winning this contest. They put a big old medal around because I was winning this contest. Because this contest, I took the advice. She did a surgery. And I basically just doing the surgery wasn't enough. She still took the advice to get rid of that insulin resistance thing. Insulin resistance was not, she didn't get rid of things just because she did the surgery. Not just because. The surgery was just the tool that she used, and she used it very well. I'm so very proud of her. So she went from this with issues, and you can see the issues. No, you cannot see the issues, but she's got a happy smile on her face, as we all do when we take pictures. But she's got a happier, bigger smile here, right? So I said, well, I can't let her beat me. Now, this is a fictitious story, primarily because I started this process a long time ago. She had surgery about a little while ago. But still, I had these problems. This is true. I had pre-diabetes, atrial fibrillation, congestive heart failure, hypertension. I just showed you what my blood pressure was, right? I had hypertension when I had this much visceral belly fat. This much visceral belly fat was poison to my system. These fat cells were dying. These dying fat cells released a bunch of chemicals called cytokines. Those cytokines caused damage to my vessels. If I had the technology back then, or if they had the technology back then, I would have gotten a coronary artery calcium score, and it would have probably said, "You getting ready to have a heart attack." But so this is me. This is all me. I was 205, and I come down. I come down from 205, from 215 to 205. Great, right? But it still didn't go away. All right. It still didn't go away when I was trying to suck it in. Whenever I pursed my lips like that, I'm trying to suck it in. It decreased a little bit. Now, right down here, right down in this area here is called my waist. Okay. So I'm going to show you how to use this thing because I'm going to put this thing around my waist. Now, I don't mean the waist is around, this is where my belly button is. So you don't put it around there. All right. You put it around the top of your hip bone. You can feel the very, very top of your hip bone. You can take a finger and feel it. That's where you're going to put this horizontal around your waist, starting at that hip bone all the way around. I'm going to show you live what mine is. All right. But even when I suck it in, that doesn't change your waist to hip ratio. Your waist to height, I keep saying hip, but waist to height ratio. If you have one of these things now, you may have a tape measure, but this one is kind of cool because it wraps around your waist and your hip, and it has a little small thing, it has a little knots there that it's gonna capture, and it has another little thing, a little button that I'm gonna press to make it as tight as it'll go. So it'll give me an accurate reading. I do have my clothes on, so it's not gonna be that accurate, but I just push the top button. Then all you have to do is when push the top button, then just take it off and then read what it says. Okay, with my clothes on and everything, is 34 and a half inches. Okay. Now, what I mean by waist to height ratio, 34 and a half inches is my waist. Okay. But my height, I'm 5'10". 5 feet is 60 inches. 10 more is 70 inches. So I'm 70 inches tall. So I'm going to take my waist, 34, and divide it by 70. Okay. Waist to height ratio. I'm not going to do the numbers now. You all can do it. So I don't have another phone here with me. But my waist to height ratio, what I want yours to be, what I want mine to be, is less than 50. Okay? So you can just kind of do it in your head. Some of you guys are a lot smarter than I am. But 34.5 divided by 70, it's probably less than 50. Anybody got that? Anybody putting that up? All righty. Somebody's telling me that can my primary physician measure my VO2 max? If they have the machine, there's a special kind of machine that you have to do on the treadmill or on a bicycle. They put a mask on your face and it delivers a certain amount of O2 and CO2 and things of that nature. So it measures what your oxygen utilization is while you're actually increasing your thing. So it's an expensive machine. We carry it. And we use it primarily before we get patients to start their drugs and to start their processes. A lot of you have already seen it. All right. So anyway, waist to hip ratio. No, nobody figured it out yet. But so anyway, this is me now. Nah, this is me and AI. All right. So I said, I wonder if I could take one of these tools and make myself look like what I want to be. This is me before. This is me now. Nope. This is me now. This is the actual picture of me. This little scar right here is where my atrial fibrillation, where they actually went into my heart in order to ablate my atrial appendage tissue. That was where my atrial fibrillation was coming from. It didn't work. It didn't work. So I had to kind of do some other things in order to get that atrial fibrillation gone. This is me, the lips person again, sucking it in. So that lip sucking it in there and sucking it in here is a big difference, is it? Is it or is it not? Yeah. Yeah. So wait a minute now. She says it's 49. So she says it's mine is 49. So mine is just 1 point below 50. But as long as it's under 50, you yeah, your waist to height ratio just needs to be below 50. Somebody says it's 49. Okay, I agree. It's 49. As long as it's below 50. I want you all below 50. These are the things I ordered a bunch of these things because I'm going to be getting to give these away in the office. They don't cost a bunch. This one costs about, you can get them on Temu for about $1.50. So, but they're very, very valuable. I, I trust this more than I trust the scale, the regular bathroom scale. Unless you have one of those biometric scales that actually tries to measure your body fat percentage. Those scales are a little bit better. They're very, very inaccurate as far as I'm concerned, but because they try to tell you what your muscle mass is and your lean body mass and all that, but they struggle with that. The DEXA scan is still the gold standard, but DEXA scans can be expensive. If you want to get a DEXA scan so you can see what your true results are, it's about $250. All right, so here we go. Let's continue to go. Sucking it in, sucking it in. All right. My favorite quote: if you have your health, you have hope. You knew that, right? And when you have hope, you got everything. So no matter how down you get, but my good friend who's a singer out in California, who's gone through it all, who's gone through a lot of it, and has been homeless and has been a drug addict and has been, but now is still a very successful singer because he had one thing: he had hope. And to me now, he has everything. Still has a little bit of problems with the health care he's getting out there in California, but doesn't want to come here to Atlanta. See. So here we go. I have hope of becoming from here to here. Okay. And it may take me another 10 years, but I plan on being around for another 10 years to get there. And so you all be with me at 10 years from now. I'm going to show you that transition. All right. A couple of patients I don't want you to see here. This is a cardiometabolic lab. I use a certain type of lab to get certain things that are critical for me to start you on GLP-1s and all that. And even if you had the surgery and all that, we're going to get these labs at some point in time just to see where we're improving or not improving. Because if you don't have any idea as what your labs are, you don't have any clue as to what that scale means that I've lost this much weight. So this is a person who hadn't had surgery yet, who hadn't had the GLP-1s yet. And so we're getting started, right? So this person came in with a fasting glucose. They wouldn't obtain it. These things weren't obtained. HOMA weren't obtained. So we got to order those. I think we did, and I think they haven't come in yet. But the things that I am concerned about, the HSCRP 4.7. That number, I want it to be less than 1. That's the optimal. That's the column. So then they have the comment over here, and it says the HSCRP is high. HSCRP is your inflammation. And being more specific, it's the inflammation in your vessels, which means that it's a little bit more serious because it's in your coronary vessels, in your carotid vessels, where we get stroke and heart attacks. Okay. So the doctors that just give you the drugs and don't look at this, where are they going to go from there? If they don't know what the baseline is, where are they going to go? So anyway, look at the total cholesterol, 192. Pretty much the total is a worthless number, but that came with the package. I don't look at the total cholesterol because the total cholesterol measures in your high density, your good cholesterol, and measures in your low density, your bad cholesterol. So what the hell does total cholesterol mean? Nothing. But the HDL, which is supposed to be the good cholesterol, I want that greater than 50. This is less than 44. Again, not good. That means that it's good cholesterol, which is supposed to take away some of the byproducts of the bad cholesterol, take it away from your body and take it to your liver so you get rid of it. That's not doing a very good job of taking away the bad cholesterol. We want this number to be high sort of to take away the bad cholesterol. That's what I'm just kind of giving you a little bit of a science lesson on what you're seeing with HDL and why they call it the good cholesterol. They call it good because it's going to take as baggage the bad and get rid of it. So you want this as high as possible. And it's got to be greater than 50. Here's what's up. Triglyceride, not too bad, 79. Triglyceride to HDL ratio 1.8. Not too bad, okay? But then you read the LDL, which is the bad cholesterol, as y'all have heard it. I got a different opinion on it, just that by itself. I use this number along with these numbers to tell you if it's bad or really bad. 148. So that is high. Okay. Then I take that 148 and I say, okay, fine. That's the amount of cholesterol that these little containers are taking, these little trucks are taking. These trucks that are taking the cholesterol to the areas of the body that they need to be, they're taking a lot of the bad cholesterol to these areas. And so these trucks are fine, but there's only 3 trucks on the road. Maybe that's not so bad. So then I get what's called the ApoB. The apolipoprotein B tells me how many trucks. This apolipoprotein B, which is 112, is above what I want. That means that they're not just 3 trucks taking the bad cholesterol. There are 100 trucks taking the bad cholesterol. So what difference does that make, Doc? Well, the more trucks you haven't taken that bad cholesterol in a narrow tunnel, your vessels, it has a greater chance of those trucks running into each other and running into the vessels. When they run into those vessels, they're going to damage the tile on the vessels. That smooth tile, if you go through a tunnel and you see smooth tile, like mostly in New York, you see that tunnel, I forget what they call it. But anyway, you chip that tunnel, you chip that tile, it's going to be damaged. Then that truck is going to empty its cholesterol, and that cholesterol is going to go to the scene to repair. We thought that cholesterol was bad just because it was the gooky stuff. The bad cholesterol is not bad because it's going to repair. It's the damage to the wall and the reaction to that damage to the wall because you got too many trucks carrying the wrong bad cholesterol. So you have to pull all that together. And if you don't measure that stuff, how are you going to pull it together? Then you go down further and say, okay, fine, let's see exactly what we have. Because not only is it the generalized, this is the generalized number, the LDL is 131. Well, what size is that? Because the size of the cholesterol particle that can easily get into your small, you got that grout holding towel together. And so big LDL cholesterol can't get through that grout. And if they get through that grout, that's when they cause that cholesterol buildup. Okay? So this person, the small, medium, and large, okay? The small number. So you got the ApoB and the LDL particle number are almost always the same. Okay, they just kind of represent different numbers. That's the number of trucks carrying the bad cholesterol. What kind of bad cholesterol are they carrying? They carry mostly the small type that could penetrate beneath the vessel wall. That's high. All right. So, and the LDL large, this is kind of good because you want that LDL large to be okay. All right. Spend too much time on this. So this is a guy that I'm treating with the GLP-1 drugs because it doesn't want surgery. But this is what he's starting with. So I know where to go. I'll know when I get him on the GLP-1 drugs. I'm gonna put him on a dose, the lowest dose, and see how he does. I'm not going to follow the manufacturer's regimen of increasing from 2.5 to 5 to 5 to 7.5 to 7.5 to 10 to 12 to 15. I'm not going to do that just because 30 days has passed by. I'll measure these labs again in 12 weeks, 3 months, and I'll see. I'll look at them on the scale just because that's what everybody else is judging by. I'll look at them on the scale, and that scale will say, okay, you haven't lost a lot of weight. But if these numbers in the face of you haven't lost a lot of weight are improving, I'm going to keep you on that same dose. The whole point is not for the scale to improve right away. The scale number comes later because the scale number is measuring your muscle mass, your fat mass, and your water mass. And you basically don't want your muscle mass to suffer. If your scale number is getting less, if your scale number is getting less, and these numbers are getting worse, have I done you any good? Absolutely not. So you got to balance them out. So if your scale numbers are getting good and these numbers are getting good, I said, cool, we're on the right dose because your numbers are coming down as far as your scale that you care about. But I care about these numbers. Now, I'm going to give you the other example. 49-year-old female, person lost 97 pounds, the one I was telling you about, on GLP-1 therapy. Came to the office happy. Coming to the office saying, yay, look at what I did. And this is what I told you that I was going to do on my own. But I did use the GLP-1, but I didn't have to have surgery. Nah. So fasting glucose, 123. She's lost weight now, lost 97 pounds. I don't know what her numbers were beforehand. I think, because she didn't get the GLP-1 therapy from me. But this is what when we wake up in the morning, we measure your glucose. We don't want it to be above 100. So hers is high. Her fasting insulin, which is even more important, meaning that just to keep that glucose at that level, she's got to have 17 international units per milliamps of insulin. Well, we want that number down to between 3 and 6. So she's pumping out insulin, to keep that number that's still high. She's a diabetic. Now, she wasn't before. A home RA wasn't obtained, but you can easily make that calculation. There's a way to make that calculation. Hemoglobin A1C, 6.5. This is what we wanted. Type 2 diabetes, right? HSCRP, 6.2. We want that number less than 1. She's lost 97 pounds. The numbers are going, I don't know if they're going up or not. They may have been like this in the beginning. I don't know. But HSCRP is up. Total cholesterol is up. Like I said, I don't pay too much attention to all these other numbers. But the numbers that I do pay attention to, the LDL cholesterol and ApoB, the particle number and the LDL particle number and the ApoB, amazingly high. I mean, she's got a significant amount of bad cholesterol in her blood, and she has also got too much of the small amount that can dig into the vessels. Okay? So this lady basically has all the things that worry me, even though she thinks because that scale has dropped that she's healthy. So I sent her for a coronary artery calcium scan. She's got calcium built up in her coronary arteries and her carotid vessels. She's at risk for a stroke and a heart attack. But she lost 97 pounds. So, ladies and gentlemen, the whole moral of that story is that do not go into this thinking that you're healthy just because you're losing weight. If you're losing the wrong type of weight, you're going to get sicker. All right. So don't go just buying these GLP-1 drugs out of a vending store, off of certain websites and all that kind of stuff without somebody measuring something on you. Okay. All right. Anyway, that's that. I'm going to stop that share, and then I'm going to show the videos and show you how we're going to pull all this together. How what I said we're going to pull it together. So remember all that I said. All right. So let's see if I can figure this out again. Share. We'll share on desktop again. Let's see if I can go to. Oh, brother. I got to get to my Chrome, right? One of my Chromes. That ain't it. One of the other Chromes. That ain't it. How about that one? That ain't it. Let's see that. This is it. All right. This is number 2. And y'all tell me which one you like. I got 2 of these videos. This is number 2. Let me go to number 1. Let me tell you. You tell me which one you like. Let's go to number 1. This is a cinematic. It's 5 minutes, 7 minutes. So we got 12 minutes of videos we're going to watch. And then I'm going to ask you some questions from the people who were here last week to let me know what y'all did as far as the action plan, because I told you I was going to ask you all that. Okay. So I'm going to play this. Let me stop it real quick.
If you follow the current medical conversation, you might easily conclude that traditional weight loss surgery is becoming obsolete. We're seeing a surge of highly effective GLP-1 and GIP receptor agonists. Medications like the Wegovy and Ozempic pens shown here routinely help patients shed 15 to 20% of their body weight in clinical trials. As a direct result of these pharmaceutical successes, national bariatric surgery volumes have measurably declined. It raises a logical question. Why undergo a permanent invasive operation when you can achieve similar results with a weekly injection? Framing this as a choice between a scalpel and a syringe ignores the biological reality of severe chronic obesity. The problem with relying solely on these medications for permanent weight loss becomes obvious when we look outside of clinical trials and into the real world. This chart tracks GLP-1 adherence over 12 months. Up to 70% of patients drop out within year 1, triggering rapid weight regain. Overlaying surgery data reveals a sustained trajectory. 96% of surgical patients maintain their weight loss over 2 years. Surgery is definitely not a flawless cure. Over the course of years, a portion of post-op patients will hit long-term weight plateaus or slowly regain what they lost. But real-world data across hundreds of thousands of patients proves that the old tiered system, where you try drugs first and only resort to surgery if they fail, is outdated. Instead of competing, these 2 treatments perfectly cover each other's physiological blind spots when used together. The synergy starts before a patient even reaches the operating room. Doctors now use GLP-1s to prime patients with a BMI over 50, helping them safely drop weight and reduce the physical risks of the operation. Then there is the procedure itself. Endoscopic sleeve gastroplasty, or ESG, is a less invasive incisionless technique. Historically, it yielded...
They're talking about the ESG, and this is a study. This is from a study. But we're doing the same study and getting the same results from the sleeve gastrectomy as well. So just kind of wanted to point that out. This is one study on the ESG, but it's what they're going to be talking about is the combination. Okay?
Is a less invasive incisionless technique. Historically, it yielded lower total weight loss than a full gastric bypass, but clinical trials are testing a new strategy, performing the ESG procedure and then introducing a drug like semaglutide exactly 1 month post-op. This bar chart compares the 12-month outcomes of those 2 approaches. ESG alone produces an 18.6% total body weight loss.
So give you some perspective, 18% is on the order of what the drugs can do by themselves. All right. And so the ESG and the sleeve gastrectomy, you lose a lot more than that, but it's a little more invasive procedure. So our whole goal was to see, okay, fine, what if we quit having the drugs compete? We have them against surgery, and let's use both of them to see if we can get to both worlds. So what they're going to be talking about is what the advantages and the disadvantages are of surgery alone, and then of the drugs alone, and then with them combined.
But when ESG is combined with semaglutide, that number jumps to 25.2%. By introducing pharmacology early, patients are matching the results of highly invasive surgeries without taking on the severe anatomical risks. This combination strategy is also solving one of the most frustrating aspects of traditional bariatric procedures, long-term weight regain years down the line. The initial surgical procedure leaves the digestive system anatomically and hormonally altered. Because of this, the body's cellular receptors become highly sensitized, reacting aggressively to any newly introduced GLP-1 medications. Thanks to this sensitivity, researchers found that 78% of post-surgery patients who regained weight could shed it again using only 1 milligram per week or less of semaglutide.
So that's where the aha moment is coming in. Because the aha moment is saying, oh, okay, fine. What if we use this drug and then for the people who are stalling, I mean, what if we do the surgery and for the people who are stalling, and let's see if we can add the medicine then. But you know, the medicine had a problem with nausea and things of that nature. He says, okay, fine. What if we gave a lesser dose after the surgery? They say 1 month after the ESG. We're doing 6 months after the sleep. What if we give it a lower dose that doesn't cause the nausea? And so they tried it with this, and we're trying it with this, and that lower dose works. And what that produces is because when you come up with drug shortages, it's because you're using the 2.5 to 5 on all that. But if you start with a lower dose of semaglutide or tirzepatide, 6 months later or a year later when you stall after the surgery, you're going to start at a much, much, much lower dose, and your dosing is going to be less. And so obviously, the drug is going to be less expensive and less nausea, which are the two main reasons that people stop using the drug. And on top of that, I'm doing a trial of patients where I give the lower dose after surgery, 6 months to a year after surgery, not only giving the lower dose, but also giving it less frequently. Maybe not once a week, maybe once every 2 weeks. And we're comparing that. And the results are beginning to be impressive. So you had surgery, you stalled, and you hadn't lost all the weight that you wanted to lose. We again measure your parameters to say, okay, fine, we're just not interested in just losing the weight. We want to make sure you're getting healthier. We check the lab and we say, okay, you're getting healthier. Now let's go ahead and increase the dose to see if we can lose more fat, not the muscle mass. Because if we just keep chasing the number from 1 milligram to 2.5 to 5, and we just keep chasing the number, you are going to lose muscle mass. And that's the problem with the way that they're using it now. They measure your scale, they measure the calendar days of every 30 days, and they increase the dose. And they increase the dose, and then they come back and measure only your weight. They're missing a big picture there because they're only measuring your weight. That weight is going to be 40% of that weight that you've lost, that you're celebrating about, that the lady that I showed you the slide about celebrated about. That weight loss was muscle mass. And muscle mass is crucial for your metabolic health. All right. Sorry about that interruption. I'll go ahead and continue.
Using a 1 milligram dose, like the Wegovy pen shown here, means patients are taking less than half the standard dose prescribed for obesity. This effectively eliminates common side effects like nausea and helps bypass global drug supply shortages. The surgery alters the patient's biological baseline. It takes a treatment that typically requires high, lifelong dosing and turns it into a highly effective, low-dose metabolic tune-up. When we look at obesity management over a patient's entire lifetime, we also have to account for economic sustainability. Health economists measure the value of a treatment using quality-adjusted life years, or QALYs. 1 QALY equals 1 adequately healthy year of life gained. Claims data shows that over a 2-year window, the total cost of care for a surgery patient is over $11,000 lower than maintaining someone on full-dose GLP-1 therapy.
I hope y'all heard that statistic. May have it repeated again. Because what the drug companies will tell you is that they want you on this drug for the rest of your life. And it's okay to be on the low effective dose of the rest of your life if indeed you're treating something else, but not weight loss. Not weight loss. Because I'll take the drug for its anti-inflammatory effects. Okay, I'll take a much, much, much lower dose. The tirzepatide, I'll start the tirzepatide at 1 milligram. All right. And I'll take it not because I want to lose weight, but I want to decrease the anti-inflammatory effects. But when I want patients and all that to lose weight, I tell them, listen, the best thing for us to do the best thing for us to do is to combine the approach, get rid of the effects of the GLP-1 treatment. I mean, the side effects of the nausea of the GLP-1, and at the same time, make you lose the right amount of weight. And that way, once you start getting into the habits over this time period that I'm combining these therapies, once you get into the habit of eating the foods that you're supposed to eat, I'm going to take you off the drug. The drug is not going to be for lifetime. Period. Because everything that you eat, as far as protein and the right type of fibers or leafy vegetable carbohydrates, will also decrease your inflammatory markers as well. Okay? All right. Get back with you.
The total cost of care for a surgery patient is over $11,000 lower than maintaining someone on full-dose GLP-1 therapy. This visualization tracks long-term financial trajectories. We see the sharp upfront spike of surgical costs quickly eclipsed by the compounding infinite cost of full-dose lifetime prescriptions. Combining GLP-1s with surgery ultimately say anchor the patient's metabolism. Relying solely on lifelong drug treatments becomes mathematically unsustainable for the healthcare system. Clinical evidence makes it clear that severe obesity is a chronic relapsing disease. It cannot be permanently cured by a single isolated tool. We are moving into an integrated care model. Surgery provides a durable physical foundation, and medications provide intermittent metabolic fine-tuning, interlocking perfectly for long-term stability. The public conversation pitting the scalpel against the syringe is a manufactured conflict. The future of treating severe obesity means abandoning that competition entirely and embracing how effectively these two approaches work together.
All righty. Let me see if I can. That was the cinematic view. Okay. Well, let me see if I can now give you the other view. And just share the same desktop again. If I can get to it. Not it. That's not it. Wish I had somebody that can tell me how it goes away like that. Take this down and just go to the other one. Studio, then the number 2. This is the explainer. I may have to stop this a little bit, but it's 7 minutes, and then after this 7 minutes, then you can ask some questions. I'm going to briefly show you how to use these bands for your resistance training, because you have to have some resistance training in your protocol of exercise. And I just want to show you. The other thing, in the meantime, since everybody's quiet on the chat box, I want to know several things that I should have asked you in the beginning. I want to know how many grams of protein everybody took in yesterday or every day this week. And then the second thing I want you to begin to sort of populate in the chat box as we watch this next video is, what did you do? What action did you do? From last week, we talked about every time I'm going to ask you, what action did you do from what you've learned? Remember, the whole mantra is that knowledge is power, gives you opportunity, gives you potential, but it's nothing without taking action. What did you do from what you learned last week? Okay. So I'm going to start this one now.
All right, let's dive right into this explainer. Today, we're tackling the modern dilemma that patients face in the battle against severe obesity. For decades, the path to major sustainable weight loss was pretty much a one-way street. But recent pharmaceutical breakthroughs, they've completely disrupted the landscape. And honestly, they've left patients and clinicians navigating a pretty complex new reality. So here's the million-dollar question. When it comes to severe weight loss, what actually wins out? The scalpel or the syringe? We're constantly bombarded with headlines about miracle drugs and dropping surgery rates. But to really understand what's going on, we need to cut through the hype and look at the largest, most recent real-world data. Which brings us to section 1, the weight loss heavyweights. We've got 2 massive contenders in the ring today. On one side, traditional bariatric surgery. On the other, the incredibly disruptive alternative of GLP-1 medications. Just so we're all on the exact same page, GLP-1 receptor agonists are injectable meds, think semaglutide, that basically mimic your body's hormones. They heavily suppress appetite and really increase that sense of fullness. These injections have absolutely revolutionized medical therapy. I mean, they're driving unprecedented weight loss results without anyone having to go under the knife. And in clinical trials, they actually rival the initial effects of bariatric surgery. Moving on to section 2, surgery, the reigning champ. But here's the thing, when we pit these interventions head to head out in the real world, the established gold standard, surgery, still throws the hardest punch. The data from massive populations over extended timelines is absolutely fascinating. Take a look at these numbers. Over a 2-year window, surgery delivers an average of 28.3% total weight loss. GLP-1 therapy, just 10.3%. And check out the total cost of care. Despite the hefty upfront price tag of a procedure, surgery actually ends up costing roughly $11,600 less over those 2 years. That completely shatters the assumption that a one-time surgery is more expensive than weekly injections. And then there's the long-term durability factor, which is just striking. 96% of surgery patients keep the weight off after 2 years, compared to less than half on GLP-1s. Because, it's one thing to lose the weight initially, right? It's an entirely different biological challenge to actually keep it off over the long haul. The anatomical changes from surgery provide a durable metabolic reset. And real-world data shows that medication alone severely struggles to match that over a 2-year window. That takes us to section 3, the problem with injections. So what's going on here? While GLP-1 meds look incredible in clinical trials, they have a massive flaw out in the real world. Why the huge gap between the 15 to 20% weight loss in tightly controlled trials and the 10% we just saw in real-world claims data? Well, it comes down to this single, shocking number, 70%. 70% of GLP-1 patients abandon their treatment within just 1 year. Usually, it's because of sky-high out-of-pocket costs, severe shortages, or just punishing gastrointestinal side effects. And simply put, if you aren't taking the drug cannot work. And because these drugs literally have to be taken indefinitely, stopping them means the weight comes rushing right back. That makes them a really difficult standalone long-term solution. Obesity is a...
So I'm not quite in agreement with that. I think that the companies want you to take it for the long term, but I think that we're going to show that there's data now shows that we don't just give you the drugs and then just say take it for the long term. Now, let me just kind of tell you something that I may not really want to tell you. But if you do take the drugs and you take them long term, you can eat whatever you want to. Pizza, pasta, carbohydrates, bread, almost refined carbohydrates. You can eat whatever you want to and you'll still lose the weight. That's what, and that's what they want you to focus on. You're losing the weight. You're getting on that bathroom scale and it's going down. Our goal is not to keep you on the drugs long term to have you lose weight, which is going to mostly be muscle mass. Our goal is to keep you on it long enough to where the drugs actually cut out the food noise. The rice, the pasta, the cookies, the crackers, the refined carbohydrates that you sometimes crave, or you sometimes just eat by habit. Sometimes that then goes away after you get off of it for a while. That's what the drugs do. They take your mind off of it. And a large part of what we're eating and how we're eating and the habit of eating is here. That's what the drugs help with. And they also help with the inflammation and all that. So our goal is to have you trained to eating that salmon or that fish or that broiled chicken or those lentils along with the cruciferous vegetable. That combination, and I'll show you some of those in a second. Those combinations are crucial because those combinations are the ones that decrease the inflammation in your body on their own. So then you're not dependent on the drug, okay? So I just kind of wanted to throw that in there. Is that what they're saying now is that, yeah, you got to stay on the drugs forever. And if you get off the drugs, then the weight will come right back. Not if you follow the correct protocol. If you do the correct protocol and basically do what we're talking about doing, changing the food, because all the GLP-1, just think of a boat on a lake, and that boat has sprung a leak at the bottom of the boat. And the GLP-1s come to the rescue, and they're the buckets that are emptying the boat so the boat doesn't sink. But if some kind of way there continues to get more water in the boat is going to sink. How does the boat get more water? It gets more holes in the bottom of the hull of the boat. What is the analogy of the hull, the bottom of the boat, and the things that put holes in it? Bread, pasta, corn chips, all of those things. If you keep feeding your body the things that is destroying your metabolism, the GLP-1 drugs aren't going to really do anything other than just put band-aids over those holes. So we got to change is what I'm talking about. Okay. Last time I'm going to interrupt, I think.
A chronic relapsing disease. The moment that artificial hormone suppression from the syringe is removed, the body's natural drive to regain weight takes over almost immediately. Let's explore Section 4, the ultimate combination therapy. Okay, but what if we stop looking at these two things as competitors and realize they might actually be the ultimate team? Enter the plot twist. Adjuvant or supportive, add-on, GLP-1 therapy. Imagine using something like a semaglutide pen after a patient has already undergone bariatric surgery. Instead of treating it like an either-or scenario, clinicians are starting to use the syringe to support the scalpel, especially for patients who experience weight regain or hit a frustrating plateau before reaching their goals. When you stack these therapies, this incredible synergistic effect takes over. Look at what happens when you combine a minimally invasive procedure, like an endoscopic sleeve gastroplasty, where the stomach is sutured smaller, with semaglutide. The weight loss pushes past 25%. In a randomized double-blind study, initiating semaglutide just 1 month after the procedure resulted in superior weight loss, lower body fat, and way better blood sugar control at 12 months compared to just the procedure alone. They're effectively closing the gap between less invasive procedures and major surgeries. And here is Section 5, why low doses work. Now, you might be wondering, how on earth do patients handle the side effects of both surgery and intense medication at the same time? Well, there's a fascinating biological loophole here. For patients experiencing weight regain post-surgery, adding a GLP-1 triggers an unbelievable additional 7.5% to 9.8% total weight loss. It's basically stacking. The patient already lost a huge amount of weight from the initial surgery. By adding the medication later on, they restart that weight loss engine and push their cumulative results even higher. And here is the absolute game changer. Astonishingly, 78% of these post-surgery patients achieved this massive weight loss using a microdose of just 1.0 milligram per week, or even less. Compare that to the standard 2.4 milligram obesity dose. That standard 2.4 milligram dose is exactly where the severe side effects and the exorbitant costs really start to crush patients. So why does this work? Because the surgery already altered the patient's anatomy, the body's threshold for appetite suppression drops significantly. These tiny, highly affordable doses work like absolute magic. They virtually eliminate the severe side effects and the crazy costs that usually force people to quit. Patients get all the benefits of the medication with just a fraction of the nausea and a fraction of the pharmacy bill. It points us to a really clear realization. Low-dose GLP-1 plus surgery may be the ultimate weight loss therapy. Which leads us into Section 6, a new era of care. We are witnessing a fundamental shift right now in how the medical community approaches the chronic, relapsing disease of obesity. We're finally moving away from treating it as an acute issue that you can just fix with a single intervention. Instead, we're moving toward a lifelong multi-tool management strategy. The clinical conversation has entirely shifted from this simplistic winner-takes-all rivalry to a beautifully integrated model. Think about it. You might use medication first to lower a patient's BMI and make surgery safer. Then you use surgery for the heavy lifting and that durable metabolic reset. And finally, you deploy low-dose GLP-1s years down the line to combat the natural biological drive of weight regain. By embracing this powerful synthesis, we are unlocking what may just be the most sustainable intervention yet. If combining the durable changes of surgery with targeted low-dose hormonal support truly proves to be the ultimate weight loss therapy, the real question becomes this: how quickly will insurance companies and healthcare systems adapt to cover this new integrated era of care? We'll need you to ponder that one. Thanks for joining this explainer.
All right, thanks for listening to those guys. Now, just kind of put it in the chat box. Which one of those you like best, the explainer or the cinematic view? Our both because I can do both. But yeah, let me stop that share and turn my video back on. All righty. I like this video better. It's colorfully inviting and easy to understand. Okay. Both. Okay, good. All right. So you're putting your votes in on that. That's good. Now, some people before that, the amount of protein I ask you to take in, y'all put some excellent numbers in there. Everybody's got to be above 100. And the people who did respond to that. Those people who don't know, then that means you're not taking enough. Okay. Now I use this little thing here. Don't get paid. I don't advertise for anybody or anything. But this has what I need when I need a quicker. When I want to mix the first thing I take when I begin to take my protein is going to be whey protein isolate. It's 30 grams. For me, I need 60 grams, so I take more scoops. Okay. I mix that with water. And basically that gives me my first dose of protein. All right. And that protein is going to be around about 60 grams. So in one drink, I'll get a lot of the protein I need. Now I need more protein because I'm older and my muscles have what's called anabolic resistance. So it takes me more days of exercise and more protein in order to get what you can get at the age of 30, 35, 40, whatever. So anybody tells you that, okay, fine, all throughout your life, work out twice a week and it's fine, it's not kind of telling you the truth. You will be fine. I mean, exercise, any movement is better than nothing. But as you age, you get anabolic resistance, and basically you just got to increase your effort. That's what the young lady, Miss Shepherd, who's 90 years old, that's what she had to do, right? And she did it. All right. So people like both videos. I like both videos. Somebody taking 140 grams of proteins. You're crushing it. But the reason that I like this one is primarily because it already has the leucine in it. If you don't remember the lectures on leucine, leucine is what starts mTOR. mTOR starts the MPS, the muscle protein synthesis. You got to have that. If you're just taking in a shake and it only has a gram of leucine or it has no leucine in it, you're just taking in protein. But it's not going to preserve your muscle mass. So that's why some of these shakes, you'll show me a shake and I'll say, no, that doesn't have the leucine. And so even if you don't have the leucine in it, you can just get some powdered leucine at Amazon and just add it to it. If you have a favorite shake, or it's Premier or whatever, and you look that up and it says, okay, fine, it doesn't have, you need something with at least 2.5 to 3 grams of leucine. Leucine is the key that starts mTOR. mTOR is the key that starts the engine of muscle protein synthesis. And you got to have muscle protein synthesis. Okay. All right. What brand of shake is that one you have? It says Optimum Nutrition. Okay. It only has 2 grams of sugar, which most of them do. But the cool thing about it that I like, it has 5 grams of fiber, the type of fiber that I like. And it doesn't really tell you how much leucine it has on here, but when I looked it up and Googled it, it has 4 grams of leucine. Powerful. And it's a whole lot less than the other shakes that I had. So as I go along, I may tell you that for right now, this is my favorite, but as I go along, you are the ones that are giving me the information. You know, says, check this out, Doc. I'll check it out. And this is something that somebody else told me about. I didn't find that on my own. All right. The reason I'm standing up is that I'm getting ready to show you this exercise, right? All right. So this one right here, the green color that I showed you before, what did I do with it? Anyway, the green color. Well, the green color on these little buckles here, it says 7 pounds. I'm not going to use the 7 pounds. I'm going to go even lighter. This little green buckle says 5 pounds. Okay. So what I mean by progressive resistance training, I'm going to show the lower half of my body. What I mean by progressive resistance training is I take this and I'm going to put it on the floor. And so 5 pounds for a man of my size is pretty easy to do. So I can easily do this all day long. Okay. If I wanted to make it a little bit more resistance, I have my feet shoulder width apart. If I wanted to make a little bit more resistance, I'll just spread my feet out a little bit more, giving me a little shorter length on it. You can see my hands dropping down as I spread my feet apart. Now it's just a little bit more resistance there. Okay. But then I want to just kind of come back to put my feet together and it's easier again. Okay. So you can get different levels of resistance. Okay. So what I mean by progressive resistance, I can take this 5 pounds, I can make it feel like it's 40 pounds for me. So I do full range of motion. When I do that, and I hold it, and even if I stop right here and then just slowly roll, it's a different feel. That gives your muscles a different feel. And I won't be able to, even with this little 5 pounds, I won't be able to get to, for 5 pounds, I normally lift 20 reps. I won't, I won't get to 20 reps by any stretch of the imagination because I can feel the lactic acid building up in my muscles already. I also use the 5 pounds, and I'll change the angle of this thing. I also use the 5 pound just to work out my shoulders because this is the same kind of thing. 5 pounds on the shoulders is good. You can do it fast like that if you want to, but I don't like that. I like to use the slow control motion. All the way up and then all the way down with the arms parallel to the floor. Okay, that's what Andrea told me. Up all the way to the down. So you want to do eccentric and concentric. Eccentric, you push up rapidly, push up, you come back down. If you do this, what does this look like? This is look. This looks like you're putting your bags in the overhead bin in the airplane without any help. So you're putting your bags in the overhead. So that means you're traveling. That means you're getting ready to go into the beach and enjoy life. That felt great. So you do that. And like I said, you can just do, and I'll show you another couple of exercises next time around. You can do that with this, with the, what do you call it, the arm lifts. That gives you your shoulders, your exercise. I use this exercise along with this exercise, and you don't have to go to the gym. These things, I got 5 pounds, 7 pounds, and if I ever really want to get really, really testy, I'll go up to 19 and then get the heavy duty hitters here right here, which I hardly ever get to unless I'm really feeling like the Hulk. But this is and that's the power of these bands, is that you can change the resistance. This says 30 pounds. Well, a 30-pound weight I have over there, not a problem. But I can make this 30 pounds feel like 60. Now, 30 pounds shouldn't be that hard. But I've just adjusted the resistance by taking my feet and putting them further apart and slowly doing it. So that's why I can't do too many of the heaviest one that they have is 30 pounds. They may have heavier than this, but that's all I went up to because that's going to give me my full workout. So if you want to get this, it's fine. But you really don't need handles with the green and the yellow. That's all you really need. Because you can make your exercise whatever you want it to be. All right. So, old man got to sit down. All right. Let's see. All right. So you all put it in there how much protein you have. So your goal next week is for everybody on here. I only had a few people that tell me that they increased their protein. I don't know, a few people on here that tell me that they took in their fiber before the meals. Maybe one or two people. I want to have the majority of people in the chat box telling me that they increased their protein. And to me, I take this 3 times a day. And the reason, I mean, I basically ate a salad with some chicken in it yesterday, and it filled me up. I didn't finish the entire salad, but I said this is not going to be enough protein. So I take this 3 times. Actually, I took it 4 times, which gave me 160 grams of protein. About what I need. and I got my my taste buds okay, primarily with the salad. So I didn't eat a whole lot yesterday. But what happens is that if you're on these drugs and you're not eating a lot and you're seeing your weight go down, you can pretty much guarantee it's muscle mass. And you don't want that. Because again, you're not going to even feel that you want this, but you can take this down a lot quicker than you can take a chicken piece of chicken down or a piece of fish down. Because when I tried to eat that salad, I kind of had to push the chicken to the side, which is not what I ate a couple bites of it, but it's difficult when you're on the drugs because you're not hungry, and and that's a good thing that you're not hungry because you're cutting out the food noise. You're training your body to cut out food noise, but you still have to get your protein in, and the only way that you're gonna get your protein, and this is why I emphasize shakes, is that if you listen to your body and you're not hungry, you don't eat, and you're not hungry, you're gonna lose muscle mass, and that's extremely important for you not to do that. Okay. All right. All right. I have to get on track and stay on track. Being consistent has been my problem. Let's be consistent by coming to these things because I'm going to teach you something every week and then I'm going to ask you to take action. So everybody on here today, next week we're going to see what action you took. We're going to do a different type of band exercise. And I want you to go out right now and just do 1 mile of walking today. Okay. Just go ahead and do zone 2, 1 mile of walking. Okay. And we'll talk about a different type of zone 2 next week. You know, 4 minutes on, 3 minutes off, 4 minutes on, 3 minutes off. And I'm going to be talking about your maximum heart rate when I talk about those 4 minutes. Okay. All right. Let's see. So I said I eat more protein daily because I get bored with the protein shake. And taking protein shakes are boring, but losing muscle mass is not an option. Okay. All righty. Very good. All right. Tell me, as the last thing, tell me what you learned new today. I think I may have asked you that question before, but I want to capture it in these last notes here. All right. Anything you learned new today? Okay. 2.5 to 3 grams of leucine, brand exercise. That'll do a mile a day. All right. Very good. Very good. I have to eat more protein daily as I get bored with protein drinks. Best advice for us, husband and I, leave a box of shakes in the car as we're out. It keeps us with us. There you go. The correct way to use bands. Yeah, the bands, like I said, with just 5 pounds and 7 pounds, you can accomplish a lot. I can do my total body exercise with just the 5 pounds alone, including the arms, including the shoulders, including the arms here. And then basically you can, next week, I'll show you how to do some legs with those exercises. Okay. All right. Very good. I appreciate it, guys. Allow the bands, increase protein, use shakes and bands. Very good. All right. Well, I kept you over again. I've been trying to cut these things down, but I think this is valuable information. Valuable information is something that you can take, you can put into your hat, recognize it as an opportunity, recognize it as potential. But every week we're going to say, I took action on that. Okay. In the meantime, y'all go ahead and have a healthy day and a great day. Go out there and do some walking. This little gray over here, but that's a good thing. Not so much sun to walk out into. All right. Take care, and I'll see you next week. Bye bye.